Let's see, Ed, would you like to, sorry about that. Ed, would you like to introduce yourself?
Yeah, you bet. Thanks, Will. Good morning, everybody. My name's Ed Kaiser. I'm a family trained nurse practitioner. I live in the Omaha area. Been working with patients with substance use disorder for the last 7 years. I work primarily remotely in multiple different states with a bigger company, but yeah, probably 80% of my specialty is like Suboxone treatment, opiate use, but we also do some alcohol and other substances. So really excited to be with you guys. Thanks for joining us again.
Thanks, Ed. And Mary.
Good morning, Mary Ellis. I'm an attorney and a nurse practitioner, psychiatric here in the state of Nebraska. I work in all the communities around Omaha, and we're working a lot with substance use in the court systems and just in the community.
Thanks, Mary. Alex.
Morning, Alex Dorick. I'm a board certified family physician. I have a particular interest in infectious disease, but I've also been doing Suboxone treatment for many years now at my federally qualified health center. I'm very happy to be here because I didn't get much of this training when I was an intern when Purdue Pharma drug reps were extolling the virtues of OxyContin. So it's really good to be part of the solution instead of part of the problem.
Thanks, Alex. I got a text from John Massey. He's our pain expert. He's going to be joining us a little later. And then our other addiction psychiatrist, Stephanie Bennington. I don't think I see you on there. Stephanie, are you on? Okay, if not, Todd, I will turn things over to you.
Good morning. Can you see my slides?
Yeah, that looks great.
Okay, good. All right, terrific. So, my this is kind of the second part, and thanks for joining everyone this morning. Before we jump in and do part two, a couple things I think are I want to mention, and one is the um, if you have a topic or something that you're interested in, please let us know. I think that's uh, and it can be around substance use, pain, or other things that are even remotely related to addiction and pain. It doesn't have to be. So if you're interested in certain kind of I'll give you some examples. Pharmacotherapeutic or medication options in terms of the range of treating various types of pain, maybe. If you're interested in a topic related to how to taper benzodiazepines for somebody who's been on a long period of time, that would fit into this. So, um, those are just two examples, and I'm not saying you should choose either of those. I'm giving you a range of things that we can talk about, or some of the procedural things to treat pain. Whatever the case may be. As this echo has continued, and it started many years ago, um, we want. I think there's some overlap and duplication that have taken place over time, but we want to continue to um, present ideas and topics that are unique to the audience. And part of the reason I'm going into this is because I've been with it since the beginning, so I know kind of where things have gone with Echo. The other part that I think is particularly important is um, as we are shifting, and you'll see kind of, I think, evolving, we want to make it relevant. We want to make it so that it's practical and you can take some of the information and use it, not just that seems to be kind of a nice topic, but gee, it doesn't really apply to me. So, having said that, let's jump in. I'm going to talk about personality, and this is a follow up to our um, start of personality type one. So let me tell you where we're going today, because I did not put specifically an objective slide. That was kind of mentioned in the previous one. And so I'm just going to kind of pick up, but I'm going to review what a personality disorder is. I'm going to describe briefly the classes, the current classification, and mention some key features of each personality disorder. And then we're really going to get into substance use and some of the factors to think about when it comes to someone developing comorbidity or having a personality disorder and then a substance use disorder. So that's where we're going today, and happy to try to entertain any questions that may come up. So when you think about a personality disorder, there are various components that are involved developmentally, genetically or biologically, experientially, and clearly people that have more challenging upbringings are more likely to develop a personality disorder. That is adverse kind of experiences in their life are more likely. It doesn't mean they will, but they have more of a diathesis to do so. So it's a pattern that's across the spectrum of life, if you will, that really is maladaptive. It results in problematic kinds of issues. And let me use an example that is frequently um, overlooked, and it really, I, I believe, is an important thing. Many times we'll treat someone that has depression, and their depression really is characterologically based. In other words, it's related to the personality. It's not considered quote unquote a just major depressive disorder. It is due to the maladaptive kind of components that are a part of personality that fall under the four areas of cognition. So people that have a personality disorder misperceive situations and people and comments and things that are made, comments that are made, and they're true to them. And not they could be almost delusionally proportioned, but they're true to them, and it's others that are misperceiving in their mind. It's not I'm off with my thinking, it's someone else is off. And so because that's the way they register it, and that's their experience and what they trust as their experience. Individuals often have trouble regulating their emotions, so that emotional response and difficulty regulating kind of their emotions goes along with difficulty recognizing facial expressions in others. And often um, there is a fear or a disgust or a hypervigilance component to that emotional kind of affective component. So there's an intense kind of labile possibility. And then, if you will, within the interpersonal kind of functioning, not only is there we've talked about kind of misperception, but there's a difficulty getting along with others and managing others in relationships and managing, even more importantly, oneself in a relationship. And then there's a component of impulsivity, and impulsivity is a part of many kind of uh, components of mental illness. So if you think about a personality disorder, there is difficulty in, if you will, one's identity, how they experience themselves and with their boundaries. And there's difficulty, and a cardinal component is trouble with self esteem and accurate self appraisal. There is trouble with kind of, if you will, self direction in life. And then there's that last kind of component that I talked about, trouble with interpersonal functioning and trouble with empathy. And remember, empathy is not only there's really kind of three components to empathy. One is I know I should feel bad. That's the cognitive piece. The other is I do feel bad. That's missing in narcissistic personality disorder, not the cognitive part, but the emotional. And then the third part, which is largely underappreciated, but very, very important, is how do others experience me? And having an understanding of how others experience you and your style or personality. And then there's often within personality disorders that goes along with that interpersonal component, difficulties with intimacy. So here's a summary of cluster A. Cluster A is paranoid. These individuals, as a refresher, are suspicious and they hold grudges. They tend not to be unlawful or psychotic. Schizoids are aloof and cold and detached and unemotional, not seeking relationships, not really involved in relationships usually. Schizotypal, they're odd, magical thinking. These individuals usually are not paranoid. They can become delusional, but that you experience them as kind of strange or different. And they talk differently, have different phrases and different, excuse me, nonverbal expressions. The cluster B are antisocial. These individuals have conduct disorder before the age of, uh, or by the age of 15, and then go on to develop antisocial personality. They tend to be impulsive and lie, cheat, steal, um, and are aggressive and have significant kind of other problems in their life as well. This is often the unappreciated personality disorder. Borderline, is on originally got the name between neuroses and psychoses. These have intense, unstable, impulsive relationships. They have identity disturbance. Who am I and where's my place in the world? They often are chronically suicidal and may have self-injurious behavior. The histrionic or the theatrical, seductive, but not so much interested in sex. They're dramatic and they are not as chaotic as what the borderline and within cluster B. And then narcissistic, this group is entitled, they lack empathy, they are self-centered, they have significant difficulties with self-esteem regulation. Um, they have difficulty recognizing emotional expression. They tend not to be unlawful, but they not uncommonly are dismissive, and they struggle with learning from their mistakes, and they often are present interpersonally as vindictive and intrusive and dominant. And again, they are oblivious to many of those features. Cluster C, the avoidance, these people are feel inferior. They need people, but they fear rejection. Avoidant looks a lot like social anxiety disorder, um, and where they may draw attention to themselves or humiliate or embarrass themselves. Dependent, this group um, often needs relationships and they're indecisive and they fear abandonment, and they will be in an abusive relationship uh, many times because that's more comfortable for this personality style, even though it can be, horrific, than being alone. And then obsessive compulsive, these are misers, rigid, perfectionists, often firstborn. They're mechanical. They don't delegate. They have to do it themselves. It's different than obsessive compulsive disorder, the personality disorder. You can have both, but it is not the same as obsessive compulsive disorder. So when you think about the prevalence across studies, it's about 10% for someone in the population to have a personality disorder. And if you think about not only across the spectrum of personality disorders, meaning mild, moderate to severe, you'll see that obsessive compulsive disorder, the prevalence rates, and I'm just giving you a few of them here, somewhere around, basically 4 to 8%. Narcissistic is from lots of studies put together is around 6%. Borderline, ranges. This is in the general population now, okay, 1 to 4%. Paranoid about 4, and antisocial about 3%. If you get into a different population and a psychiatric population, that is, that have a mental illness, these numbers tend to change and they tend to go up, and you'll find increased. For example, people that are going into the hospital will have borderline personality. Doesn't mean they can't have others, but you'll find those numbers for borderline personality that go into a psychiatric hospital are much higher than in the general population. So we know that what are the risk factors for developing a personality disorder and substance use disorder? There's shared genetic and biological factors, um, including kind of especially, and you'll see this in impulse control, in harm avoidance, and risk taking, in emotional kinds of uh, responses, so that neurobiological kind of vulnerabilities make someone much more prone. And then environmental and developmental, where we hear over and over and over about the effects of adverse childhood experiences or adolescent experiences. But then that upbringing, where there's a tumultuous, chaotic, unpredictable kind of environment, where there may be emotional abuse or physical abuse, and often unappreciated parental hostility, and or parenting styles that can be problematic. For example, overvaluation or leniency, or invalidation, or lack of warmth or coldness. Those kind of components often will contribute to developmental factors in developing a personality disorder. As a result of the environmental factors, you will find, uh, and this is not a talk today on attachment styles, but it's really important because attachment helps create a sense of kind of how to manage the world and security and so on. And so, not uncommonly, someone who has a personality disorder will struggle with a particular attachment style, and that's uh, I'm not going to say any more about that, but it is a key element. So, what are some risk factors again as we continue? Comorbid psychiatric problems, so mood disorders, especially bipolar, for disorders associated with substance, and you can find personality disorders with that, and PTSD. A component that I've already mentioned several times across the spectrum is the idea of impulsivity, and then the idea of getting a response that's rewarding from self-medication. Other factors that contribute are difficulties within relationships or social isolation, and attachments, which I just spent a little time mentioning. And then not uncommonly, risk factors like poverty and economic kind of components can, but not always factor into developing a personality disorder and substance problem. How about what causes, when you think about the comorbidity of personality disorder and substance? Well, there's the thought that the primary is a substance use disorder contributes to the development of this, but there's not. That was years ago, and in fact, we would um, categorize years and years ago substance use disorders as a type of personality disorder. Well, that didn't really bear out. Behavioral disinhibition does factor in the inability to regulate one's emotional and behavioral responses, if you will. Um, and there are genetically kind of predetermined or characterological traits that, or temperamental, excuse me, traits that go along with this that include um, risk taking and low harm, harm avoidance, meaning people do things that it can result in harm. Then there's it got a lot of attention for an extended period of time, reducing the self-medication process of reducing stress, including especially anxiety and mood. And there's some merit to that. Um, and factored into that are things like benzodiazepines or sedative hypnotics, and which would include alcohol as well. And then reinforcing, as I've mentioned already, that novelty seeking, risk seeking, extroversion, that's that reward sensitivity. Um, and they there is some commonality with some of the wiring from what are called connectomes in our brain that have to do with developing um, certain patterns of behavior and reward from the patterns, including drinking or using a substance. There's a strong association between psychiatric problems that are externalizing and a substance use disorder. So, what does that mean? Internalizing disorders tend to be things like mood disorders, like depression and anxiety. External are impulse kinds of things, ADHD, conduct disorder, antisocial personality. Those are externalizing disorders, if you will, oppositional defiant disorder as a kid. And I'm bringing a lot of things up in the adolescent realm because that's where often, between the ages of 12 and 25, psychiatric problems and substance problems begin. Most psychiatric disorders start prior to developing a substance use disorder. So that's a key thing to remember because remember that the tenets for developing a personality disorder or a psychiatric disorder often happens prior to addiction. And personality disorders not only have a large impact on functioning, but you will see that these characteristics, whether it's developmental that is contributing or environmental or that genetic predisposition, you'll see those things start to emerge in sometimes earlier in life, even in that early kind of teenage years, but not uncommonly as one's emerging into adulthood, where they'll start to develop maladaptive kind of characteristics or traits that are then followed by the use of a substance. So the prevalence of a substance use disorder is with schizotypal, and I'm using this as an example, is pretty high. It's 44% and 50%, and this is from studies that I'm now with borderline personality, and roughly 40% with narcissistic, and so on. So antisocial has the highest rate of substance use that accompanies it, and a strong kind of component with fathers and sons, and their wiring is different. I think I mentioned this last time. There's been consistency in terms of studies to show that those individuals that have antisocial personality disorder, that develop a substance use disorder, are not affected the same way by the ingestion of a substance, especially with alcohol, which the numbers are much higher for alcohol in this population. Let me say it differently. First time they drink a six pack, and that's what it takes to get a buzz. Their other friends that they're with drink a half a beer, and they're kind of feeling a buzz. And so they experience tolerance and the euphoria differently within their brains. And that's really important to remember. Um, the three that are particularly higher, including narcissistic, but antisocial, borderline, and schizotypal personality disorders, have a much higher odds of developing a substance use disorder involving the most common substances that are out there in our culture, alcohol, especially alcohol, tobacco, marijuana, and the opiates, which we often talk about in this group. So, what about the risk for onset? Let's talk about that. When do these, onset of any substance use disorder during what's the risk for each cluster? You can see cluster B is by far overrepresented. So cluster B, again, antisocial, narcissistic, borderline, and histrionic. And this group is by far overrepresented in terms of the risk for onset. So when you're seeing a patient that you have some suspicion that has some of the features with a personality disorder, especially within that cluster B spectrum, have in the back of your mind that they are at risk for developing an SUD, and the earlier the intervention, the better the outcome. How about when we look at onset at 1 year for a group that has a diagnosis of the personality disorders mentioned here? So, here we have most of the personality disorders listed, and what are the odds ratio for developing an alcohol problem or any drug problem if you have this personality. And you can see the asterisks for alcohol are under paranoid and schizotypal, borderline, and histrionic and narcissistic. Um, and believe it or not, in this particular study, which was done in 2009, which was a large study, antisocial did not show the risk for alcohol, but over the course of time, by far and away, it's got the highest risk. And any drug dependence you'll see, um, and so you say, well, gee, dependent, I wouldn't expect that. These individuals are anxious and fearful, so they're often using sedative hypnotics, if you will, within this population. I've only used studies here that have are either multiple studies put together or systematic studies. So um, these are not just isolated small studies. How about drug use disorder and risk for onset overall from this smaller group? And you can see antisocial starting to now show up more. This is a different group from Compton and who did an analysis of multiple studies. And you can see the point to remember is people that have a personality or develop personality problems are at risk for developing a substance use disorder. And you will find many of these individuals that are originally diagnosed, and I said this before, but I'm going to say it differently, and that's why I talked about characterological depression. Characterological meaning depression secondary to a personality disorder. Many individuals will come in and they'll have the diagnosis of a psychiatric diagnosis, of depression or anxiety and so on. And if they meet criteria. You say, well, gee, they have their moods down or irritable, and they're anhedonic, and they have trouble with sleep and energy, and they're fatigued, and they don't focus as well, and their memory's not as good, and they're nihilistic, and have a negative lens on the world of themselves and the future, and so on, and they may even feel hopeless and have thoughts of ending their life. And if and that may be the case, but if it may be that it's the emergence of the inability to manage the world and their life, and they get particularly distressed, and so it becomes characterological, and so that's where they may start to use substances or alcohol or drugs, and so you really need to be thinking about kind of the comprehensive treatment of what's going on with that patient. How about someone who persists with problems? And remember that once you have a personality disorder, that doesn't mean that it stays with you for life. We used to think that for some of them. That is true for some, but we used to think that was pretty much the case for all. For example, borderline personality, if they get the proper kind of treatment for borderline, whether it's dialectical and behavioral therapy or transference focused therapy or psychodynamic therapy, these individuals often will do particularly well. And so it's not true that there's a persistence for all personality disorders, but for those individuals that have a personality disorder that's going on, what is their risk for persistence of a substance use problem? And you can see now antisocial starts to go up or leads the way again. Schizotypal often surprises people. Remember, these are the odd, eccentric, kind of strange, magical thinking kind of individuals. And it's not uncommon for them to develop a cannabis use disorder, as noted in this slide, or alcohol problems as well. The asterisks represent those that are clinically significant. Now, this is a really busy slide, and I don't want to get too caught up in it. I just want you to note that the bolded cluster personalities within a cluster. So, for example, cluster B, those that are bolded at a 3-year course, so bolded meaning the numbers are bolded themselves, represents a statistically significant problem um, for these individuals. So antisocials across the spectrum for alcohol, marijuana, nicotine, and drug use. Borderline the same. Narcissistic is mainly for alcohol at 3 years. Schizotypal is across the spectrum. So the trend here is, if you will, antisocial, borderline, and schizotypal have the strongest kind of association with persistence of a substance use disorder at 3 years. And we often don't identify not only antisocial, but schizotypal. Think about if you're in primary care, think about the last time you thought about that personality disorder. It's not very common that people think about it. And I'm not being critical of anyone. It's just doesn't hit the radar. But yet, what's the risk factors that go along with it? It's like saying in another. Let me give you an analogy within the psychiatric, or let's use medical world and psychiatric world. If you have uh, bipolar disorder, your chances of having a substance use disorder are somewhere between 60 and 70%. So you think, oh, I need to be looking for that if somebody's got bipolar disorder. If you have a autoimmune disease, let's say you're type 1 diabetic, your patient is a type 1 diabetic, your chances of having another autoimmune disease are about 20%. So you're thinking, okay, do they have thyroid problems? Do they have, whatever else that may be autoimmune, psoriasis, whatever the case may be? And so um, in this case, think about somebody's got schizotypal or antisocial or borderline. Gee, maybe I should be thinking not only about other psychiatric diagnoses, but substance use in particular. So if you think of kind of ranking, if you will, and just uh, predisposition included, environmental components included, who are the ones that who are the personality disorders, or what are the personality disorders, and who are the individuals that tend to develop kind of problems with alcohol and drug? Well, antisocial, you've heard me say that over and over. Histrionic with both, but less so than antisocial. Dependent mainly with sedative hypnotics. So when it says alcohol or drugs, these are sedative hypnotics, which is also true of histrionic, and I should have mentioned that. Right? They want to dial down the emotionality. Borderline frequently with substance, and then schizotypal, you've heard me say that, and narcissistic would go within that group as well. So let's break it down a little bit. Prevalence of borderline personality disorder and a substance use disorder, right? And I said, once we get into this population, not only does psychiatric comorbidity go up, so depression, other mental health problems, whether it's anxiety or, but addiction does as well. So the odds ratio of developing alcohol problems is very high for somebody who has borderline personality to develop either a drug problem. Remember, drug problem could be nicotine, right? And we often overlook that. Or it could be alcohol in itself. So pretty high when you look at the 12-month prevalence for alcohol problems as well as lifetime. And I don't need to read you the numbers. What I want you to remember is, gee, borderline personality, that's there. If it's an active diagnosis and they're struggling, really be thinking about, are they also having trouble with substance use? What do we do for that group? Well, we want to reduce the behaviors that go along with kind of problematic substance use or problems within their personality, and especially those in behaviors that are life-threatening. So suicide. Remember, this group can be chronically suicidal and not need to be in the hospital, and they may have chronic self-interest behavior. That doesn't mean that they're actively wanting to take their life. Many individuals that have borderline personality will burn themselves or cut on themselves because they want to feel, and that's their sensation of feeling, because they are often numb or detached from their emotions, and so they use that physical sensation to feel. It's not necessarily always to end their life or harm themselves. And then you want to reduce the behaviors that are problematic for them and build their skills. So, right, building skills can come through um, either dialectical behavioral therapy or dynamic psychotherapy. And dynamic psychotherapy is a unique skill set that some people say, oh, yeah, I'm using psychodynamic psychotherapy, and they're really not, and they're not trained in it. It is a truly unique skill set and somewhat difficult to learn. And so um, it's whereas DBT is easier to learn and quite effective for this group as well. So I just want you to be aware that there are treatments that can work for both borderline personality and those that have a substance use disorder. How about schizotypal personality disorder? That's STPD. Empathy is an important thing, and showing acceptance, and especially if you're responding to them by laughing at their strangeness or their strange ideas, that's going to be create a new challenge for you. And sometimes it's hard not to do, right? And so it's appropriate to kind of try to be empathetic and not get bored with kind of their strange thinking or ideas, but yet help them to understand maybe there's different ways to develop social skills and help them to learn how others may experience the way they come across. And that can be done initially best through individual kind of conversations, but then often in groups where the group in a group therapy setting, they can be more accepting, and that's a part of considered what would be the therapy in terms of the behaviors and the verbal and nonverbal communication that they have and that they struggle with, as well as their thinking processes. Remember, we go back to those four cardinal features. These individuals really misperceive things. And so when they feel rejected, they use. When they feel like they're more of a pariah, they use. And so that's this group here. So think about kind of how to manage those. Now let's talk about tips for treating narcissistic personality. Remember, this group often is not uncommonly comes from childhood adversity, whether it's some type of abuse or neglect or hostility is a common thing for these individuals. And so they're developing a compensatory strategy to deal with a low self-esteem and inability to regulate their worth. And so they're really pushing um, aside those feelings and pushing them deep down inside um, to a point where they become oblivious to them. But if that obliviousness, if that shell is cracked, some can become very fragile. And within this group, then there's a spectrum of the kind of fragile narcissist, the grandiose oblivious, entitled kind of haughty exploitative group. And then there's the malignant narcissists. These are individuals that often are paranoid, and they are aggressive. Um, they have a lot of antisocial personality characteristics. And so within that malignant realm, and you will find, especially in that group, using substances. Doesn't mean they all do, but that they do, and that they are unaware of kind of their arrogance and their in how they come across. And so, if you are trying to work with someone, this group is challenging, and if you are too confrontational, um, it will be counterproductive. And so they learn by kind of learning how slowly how the others may experience them and looking at different perspectives about how others may perceive them, because they're going to tell you how they think others perceive them, which is often not completely accurate or maybe completely inaccurate. And then helping them to say, what are some other possibilities? And often it's related to a conflict they're having. So you capture that, whether it's a relationship issue with a significant other, whether it's an employment issue, and saying, all right, what if others experience you this way? Um, what could you do differently, right? And so not meaning, oh, others experience you this way, and so you got to figure it out. I mean, and I'm being a little bit curt here, and um, but finessing that situation and massaging it so that they can start to think about how others may, that there's other possibilities. And sometimes peer group can be supportive. This group, either along the spectrum, whether it's the fragile or to the malignant narcissist that I've described, can experience substance problems, and it can be across the spectrum. Alcohol is pretty common, but if somebody gets if they're fragile and down and so on, they may start to use stimulants. All right, how about the group that has conduct disorder by the age of 15 that turns into antisocial personality? This group is the rules don't apply, and even though they know the rules, they're above the rules, and they see that they can do things the way they want to. And so when they get under a lot of distress, maybe there's legal problems, maybe they're having relationship problems, maybe they're losing a job, they'll tend to use. They can do, along that spectrum, like borderline, have self-injurious behavior. And believe it or not, it's not uncommon to dissociate or disconnect, if you will. Remember, dissociation is a disorder in itself, but it's a phenomena that you'll see in people that have PTSD. And the reason I bring PTSD up is that there's a lot of comorbidity with PTSD and substance use, and some of these individuals will also have antisocial personality. So, like all personality disorders, under enough stress, this group regresses or becomes less functional. It's true of all of us in life. It doesn't mean we all have a personality disorder. That's not my point. Under enough stress, regardless of who you are, and the situation, because different people have different resiliencies in different situations, we regress in terms of our adaptation to manage stress if the stress is high enough. And so this group is not any different. And so they not uncommonly will have what used to be called Burkitt syndrome, or some somatization disorder, now called somatic symptom disorder, in addition to alcohol or drug problems. And cognitive behavioral therapy is pretty effective for this group if you have a therapeutic relationship. And then certain groups, whether it's therapeutic communities or a AA or NA group, if they feel a part of the group. But you have to be pretty careful, because this is the group, along with the narcissist, that creates what's called the 13th step in AA. And for those of you that are not familiar with AA's 12 steps, right? The 13th step is a really and I especially tell the young women, and the women, young women mean adolescents, and then women themselves, when you're going to an AA group, be aware of the 13th step. The 13th step is where there are male predators, if you will, in AA that try to take advantage of you emotionally and sexually. And they call that the 13th step. And so this group that has antisocial personality, and it's not all of them, some of them are fall in the spectrum of narcissism. And remember, there's a lot of narcissism within substance use in terms of the thinking and recovery and so on, as an adaptive strategy, but it can be maladaptive. But that 13th step is something to really be aware of, and not mean you can't go, but just don't get taken advantage of. So when you think about treatment, and I'm going to end with some treatment slides here, it's more challenging for people that have personality disorders and substance use disorders, and you need to treat both. You need to focus on both, and remember, the ingredients that determine length or determine outcomes for substance use apply here, and that's length of time in treatment, treatment of comorbid psychiatric problems, including substance problems. Replacement behaviors is the third thing. or activities, if you will, and then a strong, caring, supportive network. And so that team approach where it's integrated, keeping in mind those four variables, again, those four variables being length of time in treatment for someone who has a personality disorder and substance use, length of time, treatment of comorbid psychiatric problems, which includes personality, your network, and replacement behaviors, really, really important. And so pharmacotherapy is directed at comorbid psychiatric or substance problems. Um, there is not great kind of evidence to say it works specifically for the key components of personality disorders, but there are some of the behaviors that may go along with it that for example, aggression, or there's some that medications that may help with impulse control, um, and so on. So, for example, mood stabilizers and antipsychotics have mixed results just for personality disorders. Um, and if you look at antisocial personality, Depakote or valproic acid and its neighbor, cousin, if you will, carbamazepine, and even trileptal reduce um, impulsive aggression. So if you think about treatment and the things that are kind of really, really important with treatment, it involves kind of the basic principles of since this is a heterogeneous group, no single treatment is recommended for them all. Okay. And that adds to the complexity of treating personality disorders. And that's why I was saying that skill sets within psychotherapy, which is the backbone of treatment, um, whether it's individual or couples or family, and remember, substance problems and psychiatric problems are family problems, or group therapy, or in a therapeutic community, psychotherapy is the backbone of treatment. When someone's hospitalized, really that's your opportunity to make sure you're not overlooking a access to problem. In other words, what used to be called access to, I put it access to here now, but a personality disorder. Um, Psychotherapy, as I've mentioned, and I don't need to repeat that, the range of personality, and here's a key element. As someone has a more severe personality disorder, they're more likely to have an additional psychiatric diagnosis and a substance problem. And within that psychiatric diagnosis, it's not uncommon they have more than one personality disorder. Cluster A, although involve kind of impairment in functioning and mistrust and interpersonal difficulties, they usually don't present for psychiatric treatment. Well, I said that to you earlier in the sense when I was referring to schizotypal to say, gee, you're not probably thinking of this person has schizotypal because they're not often coming in for treatment, or you're focused on maybe some other aspect of their presentation. When in reality, part of their um, other aspect, if you will, of their presentation may be as a result of their maladaptive component to their personality. Cluster B is an extremely diverse, dysfunctional, can be dysfunctional group. And so remember that this is a very diverse group, all the way from the histrionic, theatrical unhappiness and dissatisfaction to the narcissistic patients who don't recognize their pathology. So that's another key element. And within cluster C, um, this group is often not only anxious and socially anxious, but they worry how they're going to look talking to you or present themselves. And they're going to worry about you embarrassing them or humiliating them. So they may not come in for treatment when they need treatment. Um, the obsessive compulsive group is the group that comes in that you may find kind of frustrating because they want to control things and they have so many questions and details that may or may not be relevant to their presentation. So think of the presenting problem, think about their experience, think about comorbidity and safety up front for treatment and then integrated if possible. They may need to be on pharmacotherapy, but having uh, the good therapist involved is kind of the key for this group for part of the personality, but also then the substance problems are also particularly uh, need to be addressed and particularly important for this group as well. And I say group, I'm talking about individuals that have antisocial kind of personalities or narcissistic personality, any of the personality disorders. And so um, I'm kind of at the end here. I want to go back to a couple take home points. One is when uh, you get a sense that someone is frustrating or um, you're not really wanting to go into the room to see them, or you're kind of dreading the appointment. I'm not saying it's personality disorder, but start to ask yourself, why is this happening with me? Because that may be a cue to you to say, there's something going on with this individual that is along their personality that maybe we can approach things differently. Because if they're rubbing you the wrong way, that could happen just as you or anybody can rub us the wrong way, or we can rub others the wrong way. But chances are that it's probably not just you. And so to approach these individuals and point out some of their flaws usually is not the way to approach it. It's often to say, well, how are things going and kind of the functional aspects of your life, right? How's your family life? How's your love life? Um, how's work going? How's school going? That sort of thing. So that's a way to approach it. Another key that's a really important element, with the exception of schizotypal, I'm sorry, with the exception of schizoid personality and paranoid personality, but pretty much all the rest, is a longitudinal predictor of well-being and adaption is having love in your life. And so asking them kind of, you don't need to ask them about how's your sex life. You can if that's relevant, but hey, who is important in your life? And in other words, you want to get a flavor of kind of the relationships they have in their life. And if they have connecting, trustworthy relationships, really, really important because if they don't, that should kind of raise some other flags about not necessarily, oh, yeah, this person has a personality disorder, but it should raise some flags in terms of why not, what's going on. Oh, well, I've been married, 3 times and 4 times. Okay, tell me about that. What's happened? And because now you're starting to, somebody may not be able to adapt to relationships. Now you're getting into maybe, oh, have there been other troubles with that? Have there been substance use or what have you? So I'm just giving you some food for thought in terms of how to approach individuals, and there's lots of ways to do it. So I'm gonna stop there for today. I did not bring a case particularly. I wanted to cover this, and so um, thank you for listening today and joining.
Thank you, Dr. Stoll. There is a link in the chat to the evaluation survey. We've got like 4 minutes if you want, if I mean, time for a couple of quick questions. Um, but like I said, there's a link in the chat for that evaluation survey. You can complete that to get your certificate. Also, an email will be coming out within, I don't know, an hour or two, like I said, with that same link. So easy way to get your certificate for today. We can see Roger. I see Roger, you have raised your hand. If you want to unmute, you go ahead and speak up if you'd like to. Or maybe he didn't make,
Yes,
yeah.
thank you. I'm not a practitioner, I'm an accountant, but I'm also a person with substance use disorder. Uh, so when treating, what I was thinking about, since we're talking about team integration, I know there are some like external traits that people can latch onto that may cue them into what type of personality disorder they have to better maybe approach them. Have you seen that in any of these studies?
If I understand your question right, you're asking, are there characteristics or behaviors or, if you will, observable traits that would allow you to identify a personality disorder? Is that what you're asking?
Yes, like possibly identify one so that like a nurse or maybe even the medical receptionist can better approach them to get them the treatment that they're, may be avoiding.
So it, think of it in terms of initially the converse. So yes, there are. And so let's back up from that a little bit. Think of it initially as you're interacting with this person, as a nurse is interacting, as someone's interacting with them, whoever, are they seeing the world how others would see the world? How are they perceiving the world? Are they do they struggle within, and I mentioned this a minute ago, relationships, right? Interpersonal, are they struggling at work? Those are observable things that, gee, they're not getting along, or people avoid them at work, or um, no, nobody really wants to hang out with them, or that sort of thing. Then the other is um, when observable, do they have trouble regulating their emotions? Are they, um, overly emotional or theatrical, or are they, are they kind of just incontinent, if you will, of their emotional kind of tone and state that is observable? So, emotional dysregulation is another component, and then, if you listen to them or see them, how are they living their life? You're thinking about that kind of impulsivity kind of aspect, and are they out doing things that are risk taking? Are they out drinking and driving and bragging about it? Are they, you know, and so is there that impulsive kind of component? The other thing that you look for that's, I think, um, is a sense of kind of uh, three or four other important things that are observable or you can figure out through discussions, and that is, do they have a kind of a reasonable sense of who they are and secure sense of themselves where they're not oblivious, and you can figure that out sometimes in a conversation. Do they have direction in kind of their life, right? Are they flailing around, or is there some element of direction? Do they have the capacity to empathize with others? And then I mentioned the intimacy kind of thing, relationship things that are particularly important. So it comes across from conversation, from activities, from behaviors, um, and remember, personality, we don't usually diagnose somebody walks in the door and make a diagnosis of personality disorder. It's over time where you're observing the pattern of maladaptive, functionally limiting kind of characteristics. And so, and collateral history, really, really important, right? If you have a source of collateral information, whether it's family or someone else that knows the individual well, that's pretty important too.
Hey, thanks for bringing that question up, Roger. We are at the end of our hour here, so we will call that. Have a good Friday, everybody. Thank you.